Acknowledging the sensations encountered under stressful conditions is the first piece of our preparatory information strategy. The second piece describes the external environment and the events likely to take place. This is known as procedural information. Imagine going skydiving for the first time. Procedural information would include descriptions of the events and procedures leading up to the jump, checking your pack, hand signals to use for communication, and directions for exactly how to jump out of the plane. It would also include descriptions of the noise, conditions, and potential distortions of perception, the sound of the plane and the engine, the intense noise once the door is open. And of course, it would include crucial details regarding potential problems that might occur and how to fix them. What to do when your parachute becomes tangled or fails to open on deployment. By reviewing this type of information ahead of time, you know what to anticipate and have strategies for how to prevent potential errors and respond to changing circumstances. Procedural information describes events likely to occur during the transition from normal to stressful conditions and can highlight performance errors typically committed under stress. This information can help you recognize this transition and facilitate avoidance of typical performance errors. But the practice of medicine is much more diverse and unpredictable. Crises may occur suddenly and without warning, or a situation may develop slowly over minutes to hours. The slower onset in these subacute cases may lead you to initially miss the signs that you need to sound the alarm or call for backup. And when the situation finally comes to a head, there will be a rapid onset and manifestation of stress, coupled with a new sense of urgency to fix the problem that has been slowly brewing. There are infinite possibilities of situations and circumstances that you may encounter in your work, and I can't simulate them all for you here. But maybe we can take a look at one example to get you thinking about this topic. Pediatric patients are notoriously tricky due to their ability to compensate for their underlying pathology, often fooling providers into thinking they are stable or recovering, right up until they aren't. Let's look at an example of procedural information for a nighttime shift caring for an otherwise healthy child with fever and suspected viral respiratory infection. Initially, the child seems to be doing well, on some supplemental oxygen, with mild to moderate work of breathing and mild retractions. Not much different than your other bronchiolytic patients. You begin treating their tachycardia and borderline capillary refill with a fluid bolus and maintenance IV fluids. The nurses continue this plan throughout the night, texting you updates. As the patient begins to fall asleep, the oxygen saturation drops a few points, requiring slightly higher oxygen flow. You stop by to briefly round on them with their nurse. They look relatively unchanged from before. Given the diagnosis of bronchiolitis, you are willing to tolerate a slightly lower oxygen saturation. Later in your shift, just as you're getting ready to nap before the day team returns, the nurses page you stat to the bedside. Your patient is now lethargic and obtunded. Their oxygen saturation is low, their extremities are edematous and mottled, and their capillary refill is severely delayed. The overhead speakers in the hallways blast the announcement, "Attention please stat, pediatric code blue, PCU 300, room 3025. People start showing up in droves, bringing in the crash cart and various backpacks of equipment. They each loudly announce their arrival and role and push their way to the bedside. The room becomes loud and chaotic. New people arrive asking, "What's the situation? And who's in charge here?" Your primary focus is on the low oxygen saturation, currently in the 70s on the monitor. You call for the team to prepare for intubation as you continue resuscitation. You ask the respiratory therapist to ventilate the patient while you open the laryngoscope blade. Since the low oxygen saturation is your primary focus, you move aggressively to ventilate and intubate your patient. You think to yourself, if I can just fix the oxygen sats, things will get better and I can figure out what's going on here. Quickly rushing through the steps in your head, you ask out loud, "Is everyone ready?" There's no organized response from your team. The bedside nurse giving medications is looking at you and ready to proceed. You tell her to push the induction drugs while you continue to ventilate along with the respiratory therapist prior to intubation. As you introduce the laryngoscope into the mouth, gastric contents begin to obscure your view. You yell, "Suction!" Met again with confusion and commotion, a team member scrambles to turn on the wall suction and move the suction tip into your hand. While fumbling with the suction catheter, you briefly lose your view of the vocal cords. Now cleared of debris, you see the opening to the trachea. You ask, "Who has the tube?" Somewhere in the commotion, the endotracheal tube has fallen on the ground. Your RT quickly hands you a backup tube and you successfully place it into the trachea and confirm its location. As things begin to stabilize, the tube is secured and the patient is transferred to the pediatric ICU for further care. What do you think? This example intubation and resuscitation is ultimately successful, but not well executed. How did this snowball into an emergency so quickly? In this case, the transition from normal to stress occurred over a period of time before rapidly developing into acute stress, which strained your hypothetical perspective and ability to successfully accomplish tasks. Let's back up and look at a few key points in the story. I'll describe the stressors at play and identify particular moments that allowed the situation to turn into a crisis. For starters, no one wants to wake a sleeping child, but waking your patient to conduct a more thorough exam may have revealed some warning signs. This is a potential problem that you might be able to prevent before any acute stress happens. Now let's look after the crash. Environmental stressors include noise level and ambient temperature, and crowding becomes a group stressor as more and more team members arrive. Time pressure and personal responsibility for the patient become major individual stressors. Later on, the additional complication of reflux increases your physical and cognitive demand. Seeing a patient that you recently thought was fine on the verge of bradycardia and total cardiovascular collapse is the primary stressor in this case. That is why the stress of watching the new significant hypoxemia and respiratory failure narrowed your focus onto early intubation, causing you to lose your team perspective and the need to create a shared mental model. Instead of failing to engage the other team members, there are a few things you could have done differently. Prior to beginning the intubation, you could tell entering team members to stay put while you and the respiratory therapist perform the critically important step of establishing effective oxygenation and ventilation. Once done, step back and offer the details of the situation and what you need from them. Or you could consider either passing off this task to another provider or passing leadership of the team to someone not involved in the procedure. Of course, it's easy to say we would do these things in real life, but time after time, stress prevents us from thinking of these things in the moment. Checklists and cognitive aids, in addition to interdisciplinary team trainings, can help prevent this type of situation from occurring. But this example also demonstrates that stress may prevent you from remembering or reaching for cognitive aids until after the event. It's challenging to provide procedural information for every possible scenario you may encounter, but I hope this example was able to demonstrate how you can apply sensory and procedural information to accommodate the transition from normal to stressful conditions, thus helping you prepare to do better. The remaining modules will provide a set of mental skills that you can call upon under acute stress to help you perform at your best. Let's learn how to counter the undesirable effects that acute stress has on your body and mind.